don't know the level of all the parents over here, what level they're at, so I've tried to make my talk targeted to somebody who's new, who's learning, and somebody who's a little bit more, slightly more advanced, because this is my first talk. So at the end, if you can give feedback to see what else you would like to hear, that would be helpful. So I'll start off with, why is epilepsy such a stigma? Why do we not like this word? We can use cancer, we can use hypertension. What's wrong with saying epilepsy? That's one of the things that's really close to my heart, and I would love to destigmatize it. It's not just in this area, it's worldwide. This talk is more, as I said, different levels, but this is really about the first initial consultation. You waited for an appointment to see the neurologist, you're terrified, you're scared. You don't know what to ask, you don't know what to volunteer, you don't know how to answer questions, and that's all okay because you have not been in these, you haven't learned all this. And what to do after you go home after the first visit. And I will end by giving, some guidance as to what to do in case of a convulsive seizure as well as a non-convulsive seizure. So what is a seizure? Now I'll start with some terminology. What is a seizure? A seizure is an excessive electrical discharge that's like a short-circuiting that's happening in the brain. It's usually not visible unless under a microscope or when you are trying to record with the help of an EEG and the child is having a seizure at the same time. So it's manifested as a change in awareness, sensation, movement, behavior in varying combinations depending on what part of the brain the seizure is coming from. So what is epilepsy? So everyone who has seizures does not have epilepsy. Children have seizures with fever. That is not epilepsy. But children with seizures with fever can go on to have different kinds of epilepsies that we are learning. So febrile seizures are not totally a benign thing. So that's why I'm saying not everyone who has seizures who has epilepsy. But what is epilepsy? Epilepsy is when somebody has had 2 or more unprovoked seizures. So if it's happening because of a fever, that's a provoked seizure. So that's why it's not called epilepsy. So when they've had 2 or more seizures which have been unprovoked, that becomes by definition epilepsy. It's not a disease. It's a symptom of the brain not working well. And it has many different causes. It can have brain malformations, bleeding in the brain, a stroke, infection, meningitis, other parasitic infections, malaria, or some other infections that can be present in the brain. They can all cause a seizure. Seizure is just a symptom. So 1 in 10 will at least have a seizure in their lifetime. A lot of people will have only 1 convulsion, which is the reason why we don't treat everybody after the first seizure. We wait because we want to give them a chance to see if they in fact do have epilepsy. Because the side effects of the medications, we have to balance them with the chance of having a seizure. It affects male and females. There's no predominance of which has more than the other. And it's more common in the first 10 years of life, and then by the time you enter your middle ages, because then Alzheimer's, tumors, and other conditions start taking over, which are different from pediatric age group. 45,000 children under the age of 15 develop seizures and epilepsy. That's a big number. So just to quickly go over, what are the misunderstandings or myths about epilepsy? It's contagious. It causes death. It's present since birth. And I'm just saying that these are the kind of things I, sitting in clinic, hear from people. That there's only one type of a seizure. Oh, the child did not seize. He was just staring off and he just walked off. No, that can still be a seizure. You don't always have to shake. That's the most dramatic but not the most commonest type of seizure. Then people think that epileptics have frequent seizures. No, some people are very well controlled or their seizures are not that bad and they are well controlled with medications and they don't have them so frequently. People think that they cannot go to school, cannot function, cannot do well. Julius Caesar had epilepsy. Well, he did pretty well, I think. We still know him so many years later. People think that they're dependent on others. They can swallow their tongue. So many times I've had to tell parents, it's not going to go anywhere. Don't put your finger in the kid's mouth. It's not going anywhere. And that they should be restrained. No, you're going to cause more harm. I'll talk about that more when we come to how to manage a seizure. And people always think, okay, with the first seizure, the second seizure, or the 10th, I have to take my child to the ER. If the seizure is brief, it's over, the child is back to normal or is sleepy, is otherwise doing fine, there's no need to come to the ER because the ER has nothing to do at that time, will not do anything unless the kid is in status, which means continuing seizures. Social impact includes fear, difficulty forming relationships with school peers as they grow up, financial burden of the medications, of the side effects, going back and forth to see the doctors, getting the lab tests, school problems, employment, and then for teenagers, driving becomes a big issue. And then recreational activities. Can they go wall climbing? Can they go scuba diving? I get all these questions. So there are all these things that one has to be a little bit more aware of. As I say, I don't like to put my patients in a cage. I want them to have the life that they can with reasonable supervision. Any one of us could have a seizure right now in the room, but that doesn't mean that we should put our life on hold. So, what are the most commonest things that come to mind when you first go to see the neurologist? What type of epilepsy is it? How is it going to affect my child's health or my life, if there are any adults in this group? What is the treatment? What are the side effects? Is my child still going to have seizures or not? What's going to happen to his everyday functioning? So it's really a team approach. You have to be honest. The child, if it's a preteen, tween, teenager, they like to hide these things because they want to drive tomorrow, so they will not report everything. So it's very important to build that trust relationship, and sometimes switching from one doctor to another doctor actually hinders that development of that relationship, because then the child also feels the parent's anxiety. Okay, you know what, I can't tell my parents, I can't tell this doctor. So it's very important to remember that it's a team partnership in which we all have to work together, and the common goal is that the child needs to be well. Even if you think that there's something that's unimportant, there are times when parents will say, you know, I just thought about it, I don't know if I'll tell you. I said, go ahead, tell me. Let me be the judge whether this is going to be important or not, or will have an impact on Freddie's life or not. And the same way as I want to know everything that you think may or may not be important, you feel free. There's no such thing as a stupid question. You can ask whatever. That's what I want to say, that this is what the partnership should be. You should feel comfortable asking any questions. So the first thing is prioritize. You have tons of questions. We have limited time. Prioritize the top 3-4 questions that you really want to get at this appointment. Usually the first appointment is 1 hour. The follow-up appointments are 30 minutes. But when I say my parents, I mean my patient's parents. So I tell my parents, you know what, this is going to be complicated. So when you make the appointment the next time, ask for a 1-hour visit so that we can discuss more. Things cannot be discussed in a good fashion over the phone. It's better to do it face to face. And these are all restrictions from insurance companies. Trust me, I would like to spend 1 hour with you every time, but I have all these other restrictions that are intervening between me and you. So if you feel you need 1 hour, you tell the scheduler, I need 1 hour, so you can get what you want. So prioritize what you want. Make a list, prioritize, prepare a history, ask family. Don't get them to brush things under the carpet. Let them come out, because it's going to impact your child and your child's, your other children as well. It's the siblings that get affected as well. Start a diary or a journal. Parents sit there and they expect that my computer is connected to their pediatrician's computer, or to a computer across the country if they've relocated. No, computers don't talk to each other. Information still has to be transmitted. And it's sometimes very hard to teach parents that concept. When you're coming for the appointment, make sure, are there any forms to fill? Some forms that are sent out from the clinic, nobody ever gives me those forms back. They get them, but they never bring them. I can see heads nodding here, yes?
Yeah.
And why is that? That's because we want you to think about those questions, and then rather than think at that time, oh, so what did Auntie Susie have? That's why that form is there, so you can think about it, ask Auntie Susie what it was, and then bring it. Medications. Sometimes it's better to just bring the medicines with you. If you don't know what it is, just grab the bottles, bring them with you. Or in the journal or diary that you've started, start writing everything down. All these things make a difference. Suppose 10 years from now, the child has been on 10 different medications. You don't know what they were on, what the dose was used. You don't know what side effects there were. So if there was a bad reaction and I'm seeing the child and he's 10 years old, I have no idea that there was a bad reaction. I give that medicine again because you have not provided me that history. I could cause harm, but I did not have that information. So be the advocate for your child. Have that diary or journal for your child. How often it was, how often it's given, what time it's given, and any supplements. People are a lot into alternative medicine these days, and they forget that medicines also come from natural products. So any supplement that they are on, the physician needs to know. People don't realize that birth control pill is also medication. And many times when I'll specifically ask a teenage girl, so are you on the pill? Yes, but you didn't mention it in the medications. Oh, that's not medicine. So some things to be aware of, that anything you're taking, any supplement you're taking is important. Bring other medical information. As I said, computers don't talk to each other. If you've had investigations done in Baltimore, bring it with you. It's better to bring your own stuff so that it's right there rather than me trying to hunt them down or calling a pediatrician at that time, you losing that precious 1 hour with you. Sometimes the pediatrician will offer to send them, but then offices are only as good as the people running them, and things don't get conveyed to the office in time. Bring a list of doctors that you need to get updated on sometimes. Then a child may have renal problems, may have other problems, maybe getting part of their care in Boston, part of their care here. So there has to be communication. If I'm going to use a drug that will cause renal side effects, kidney side effects, and the doctor in Boston is clueless what I'm using, or I'm clueless as to what the child's condition is, we could make the child worse. Make a list of other health concerns and bring the insurance and referral card if necessary. So the basic questions for epilepsy to ask are, what is the likely cause of the seizures? Most of the time, we will not know a cause. And some of the times, we will know a cause, and we can tell you. So when a child first starts having a seizure, it's a hunting expedition. It will take time for us to figure out what the cause is. The child will have to go through tests. We may still not get an answer. And it'll take time for the child to declare themselves, as we say. What kind of tests are needed? I'll go through some of the tests so you know what we're talking about. Is the epilepsy temporary, or is it going to be lifelong? Because that will impact on education, learning, employment, driving, all the things that I spoke about before. When do you call 911 or you don't call 911? As I said, if the seizure is brief, you don't call 911, you just let your doctor know about it. If it's longer than usual, then you call 911 and then come to the ED. How can I ensure there's no injury to my child? Again, that's going to come later on. How can I best manage other comorbid conditions? So, as I said, communicate with the neurologist what other problems the child may be having. Is he having behavior problems? Is he having difficulty in school? That's all teamwork. And this is part of the team over here. Are there any restrictions to my child? Physical activity, swimming restrictions, and as I said, climbing the wall kind of things. In addition, be prepared to ask any question that you want to. Don't hesitate. There's no such thing as a stupid question. As I showed the video, it's a journey. You learn as you go along. Make a video. If you don't know how to explain or you're too scared, the best thing is a video. A picture says 1,000 words. Now I say a video says 1,000 words. It's a small clip. Everybody has a smartphone. Majority of the people just make a video and just bring it if you're not sure what's going on. So in your handouts, there's a seizure observation record. And it's on the left-hand side at the back. This tells you how to document a seizure. You know, the date and time, the duration. At that time, it seems like it's going on for 100 years. It's not. And that will impact whether you call 911 or not. So you have to be realistic. I know it's scary, but once you've gone through a couple of seizures, if you panic, you cannot help your child. So length of the seizure, observations during the seizure, and injuries if there are any. And then you have the columns for body movements, extremity movements, what the eyes were doing, what the color of the child was, and what the mouth was doing. And there are details as to what you can just check off, because it's the progression of a seizure and how it progresses that helps us decide where it's coming from, what medication to use, what could be the potential cause of seizures. So that's all important. So if you have this, you will know how to document and report a seizure. Note any circumstances. Did the child miss a medication? Is the child sick? Was he having fun at Thanksgiving and never got to sleep more than 4 hours every night? Was the teenage girl having her periods at that time? Or anything else that you think maybe may have tipped the kid over to have a seizure when he's otherwise in good control is good to record. And if it's happening in school, your teachers are your best resources. Most of the time, it's actually the teachers and early intervention providers who say, oh, you know what, you should go get a referral to see a neurologist because what we just saw might be a seizure. You don't know how many referrals come from teachers. So you're ready, you've got all the questions, you know, you want to arrive early. Usually, I say it's just like going to the airport to catch a flight. You know, you have to find the airport, you have to find the parking, you have to find where to get there, you have to register, check in, do everything. And if you are late, so your appointment is for 9 o'clock, if you arrive at 9 o'clock at the hospital, then by the time you finally do all this and you get into the room, it'll be 9:30. I've lost precious 90 minutes. So sometimes parents will say, oh, you know what, we'll just do 30 minutes. But that's not giving me enough time with you. It won't be satisfactory for me. It won't be satisfactory for you. You'll be unsatisfied. I'll be unsatisfied because I'm not able to get all the information that's helpful for me. And my first visit with my patient is my most important visit, I say. So arrive early. Bring along something that your child may need. Snacks, favorite toys, anything else that you think that will help you keep your child entertained. Anything else that you may need, your own medications, you know, you don't want to miss your own stuff. And sometimes asking a grandmother or an aunt or an uncle or a friend to come visit with you, because at that time, in 1 hour, there's a lot of information to absorb. And it helps if there's somebody else, another set of ears and eyes to watch out and to help you and remind you of something that you've been discussing on the ride in that may help you at that time. So the neurologist tries to determine the basis of the problem. So we ask you a medical history. We ask you, so how can I help you? Why are you here? And I start off usually with that question. I'll say, so mom and dad, how can I help you? And that's because sometimes the referral doesn't say what it's supposed to say. They'll just say, you know, headache, when actually they're really concerned about a tremor or something else. Or they'll say something totally different. And so I need to know from you what you are concerned about, not what some secretary has written on a piece of paper to convey from the pediatrician to me. So what's the reason for a neurological consultation? What's been the past history? How was the pregnancy? How was the delivery? Because I'm seeing the child right from the beginning, from before conception. Sometimes children are born with IVF and may have problems, or they've donor eggs. So I need to know what the genetics of the condition I'm dealing with is very important. And some parents get really defensive and get upset that we really don't want to discuss this, but it's really very important for me to help figure out why your child may have epilepsy. Any allergies or medications that the kid is on. And during that time, what happens is that while I'm taking this history from you, I'm also observing the child. And you know, as Yogi Berra said, you can see a lot by watching, just by watching. Most of the neurological examination is done by watching. I'm seeing how the child is interacting with you, how he's playing with his toys. I can assess that. I don't have to do more detail than just observation at that time. And then I go through the rest of the exam. But that's very important. I may joke with the child, ask them who their friend is, I'll try to talk to them. That's all part of the exam because I'm assessing their cognitive development. I'm assessing whether they're able to speak fluently or not. Are they able to comprehend? Are they able to express themselves? So while having fun, we'll do that. So what are the questions to expect when I'm taking the history? When was the first seizure? Total number of seizures that were witnessed? What's the frequency? How often? And you'd be surprised, most parents do not know. And they just cannot tell. Is there anything that warns you or the child that there's going to be a seizure? Describe a seizure in detail. That's why this sheet. What do you do during a seizure? So when I hear parents say, oh yeah, Johnny was having a seizure, I just lifted him up and I brought him there. Well, then you are obstructing his airway. There are a lot of things wrong that you're doing. That's why I ask all the details. So then I can go back and educate you what you were doing right and what you were doing wrong with your child. And how long do the seizures last? What happens after the seizure? Does Johnny have weakness on one side? How long does this last? Does Johnny become combative? What happens after that? What does the child remember after he comes out of a seizure? What's the first thing he remembers? Does he remember how it started, how it ended? Do they occur in clusters? Some seizures have a tendency to have cluster in the morning, some when you're awakening. So they have different reasons to have clustering. Do they occur at any particular time of day or night? There are some seizures that are particularly prone to be during sleep. They can happen during daytime naps at the daycare center, or they can happen at night when the child is sleeping, but may never have a seizure during the daytime. Do they all look the same, or do seizures look different? You can have different looking seizures in the same child. And any seizure triggers, as I just said a few slides ago, any sleep deprivation, any intercurrent illnesses, and what, if anything, makes the seizures appear to be worse. What medications have been tried? So supposing you're coming for a second opinion, I want to know what medications have been tried, as I said before. How long was the child treated for? What dosages were used? What's the highest dose that was used? Because some doctors may switch from one medication to another thinking, oh, this is not working, but they haven't given that medicine a full chance to work. So if you have that documented in your journal, what was the last highest dose that your child was on before they were switched, it's very important for me to know, because if I want to revisit that medication, I will know, yes, it wasn't given enough chance, and there are not a lot of epilepsy medications that can be used for different syndromes, so that's very important. Then I need to know which one, and you guys are the best judge to tell me whether that was beneficial or not. What side effects, were the side effects that you could tolerate, or you just said, you know what, I cannot have him on this medication absolutely anymore. Have medication combinations been tried? Because sometimes one medication by itself may not work. The other one may not work, but if they're both used together, then they may work. And that's why it's important to know what was used before, and that helped a little bit, so maybe I can add that one again to this one to get benefit. So it's a game that we have to play to find the best medication and the best doses. Any alternative treatments have been tried. People will go for acupuncture. They'll go for reflexology. So then at that time, we will tell you what diagnostic tests to be done. X-rays, MRIs, CT scans, EEGs, blood tests, urine tests, spinal taps, all these things need to be done. Sometimes we need sophisticated MRIs, which we don't have here, and we may send you some other place. One thing is when you're just leaving, don't say, oh, you know what, I have this form to be filled. If you can come in, the first thing you can hand over, I need this form filled for the school. By the time I'm answering your questions, doing the visit, my nurse can write a letter if you want a letter for the school nurse, or fill any forms for the school nurse or anybody else. So that helps save time. While she's doing that, we do a consultation, and you're out on your way when she gives it to you. The next thing I want you to know is on the left side is a seizure action plan. I like to use this with some of my patients who have difficult to control epilepsy. And you can read through it. I don't want to go through it right now, but basically seizure information, basic first aid, when to when should the school call or you call 911, treatment protocols during school hours, and special considerations and precautions to be taken with your child. At the end of the visit, make a follow-up appointment, ask when you should return to clinic, find out when you will hear back if there are any tests to be done. We have a lot of patients. It's hard to keep track of everybody. So again, this is all about being proactive for your child. Then you just call. If you've had the test, wait for a few days, because sometimes it takes months, and sometimes if it's a lab work that's been sent out to another hospital across the country, it may take weeks, because sometimes they run those tests in batches and they're waiting for tests to be ordered from different parts of the country, and they run them together. So that's why it takes time sometimes. Or as I said, you sometimes just call back and check then when you think that it might be the right time. Know what the next steps are. Know what to expect once you go home. Ask the best way to get in touch. What number to call. Who is the point person. What to do after hours. What to do during daytime. If medication is prescribed, make sure you understand the medicine. You understand the side effects. How long it will take to show effect. What are the side effects? What should you do if you get side effects with them? And then some children cannot swallow sprinkles, some cannot chew pills. So make sure you have the right formulation for your child. And make sure the pharmacy is correct, because sometimes I'll order a medication, the next thing I hear is 2 days later, well, the medicine wasn't started because the pharmacy information was incorrect. Parents forgot that. So when you're registering at the front desk, make sure you update all your telephone, your pharmacy, everything. That's the reason to come early, because we'll just call the number that's in the system. If we have your old number, we'll just keep calling that, and that may be a source of miscommunication or lack of communication, which may be perceived negatively. Oh, nobody called me from the office. So when you call the on-call neurologist, what do you want me, what do you do? I don't know your child. Even if I do know your child, there are so many patients. It's very hard to remember each child. You give your child's name, date of birth, say, this patient is Dr. Dr. Gaetanis is okay. Dr. Gaetanis is patient. And just one brief sentence, So say, this is Jane Smith, mother of Bob Smith. My child just had a seizure. He's 2 years old. His seizures are from a stroke. He's developmentally delayed. His neurologist is Dr. John Gaetanis. I'll change it to Gaetanis and then John Smith. His seizures are well controlled, and he has maybe one brief seizure every 6 months. He's on Keppra. We went away for the weekend, and we forgot to take the medicine with us. And he just had his typical seizure, which lasted 30 seconds. What should I do? That's enough for the on-call person. That's plenty of information for me to say, okay, so Dr. Gaetanis, he's well controlled, he's just gone away, and so I'll say, so when are you coming back? Oh, we are on our way back. Okay, so it was a typical seizure, it lasted the typical duration. Do you have diastat? Yes, I do have diastat. Okay, so if he has more, I may give them parameters at that time and say, you know what, if he starts having a longer seizure or 2 or 3 seizures an hour, give him the diastat. By the time you come home, you'll have your medicine. Because they're on their way. There's no way I can prescribe a medicine where somebody who's on the road or in a flight. So just a brief synopsis like this is very important for the other person to understand your child. If you need a refill, call at least a week in advance. When you call, the phone call goes somewhere, then it gets transcribed, then it comes to us. If we are busy in clinic, we may not get to it till the next day. And if you are on your last dose at that time and you're calling in a panic, the message will not get through. So again, be proactive, call early. There's no harm in going anywhere in life early. I was here at 5 o'clock before anybody showed up. Because again, I did not anticipate how much traffic I would get. I had never been to this hotel before. I needed to figure out how to get here, where to park. So that's what I'm saying. If in life we take everything as if we're taking a flight, we'll all get somewhere. Again, as I said, if your pharmacy information has changed, give that information. Double check that then once you get the medicine, double check. Because with so many generics going on and electronic prescriptions, sometimes it's the wrong medicine that goes through. I have lots of problems with ECW, the computer system we use for communicating with the pharmacy. And the wrong preparation goes or the wrong thing goes, and it's just the click of a button, and it can be a mistake. So please make sure that the medicine is what you have been giving the child before. And if it's not, question the pharmacist. Now it's his time to be put on the spot. What changed? Did you change the medicine? Was it a mistake, or is it that the manufacturer has changed? So once you're back home from the visit, review the information you received. If you can't remember, don't understand, call. That's what this partnership is all about. Don't stay home. Don't wait for the next visit. If the next visit, I've said, come in 3 months, and you've just gone home and you don't know, don't wait. Don't go in a panic for 3 months. Call. It may take a day or so to get back, depending on how the urgency is or when somebody can get to it, but at least you've started that. Follow any instructions, any tests that have been recommended. If you've been asked not to take something, like with some tests, you may not want to take grapefruit, you may not want to take bananas or tomatoes, and if we've asked you to stop that, do that. So follow your instructions, because they may impact the testing that we're going to do. Sometimes children have braces on their teeth, and we have to send them back to the dentist to get those removed, because we need to figure out if the braces are going to be on for another 3 years. I want to know what's happening in the brain now. So dentists are pretty familiar that we will get them to get the braces off, get the MRI, and go back and get the braces put back on again. Mm-hmm. Call the office also if there's any complications or changes after starting the medication, any side effects, and follow up on your test results, as I said. Tips to help take medications. It can be easy to forget. Use a pill box. Make it a daily routine to have the medications at the same time. I try to prescribe twice a day medication, because once you go over that, it becomes very difficult to follow. Usually the midday ones. You are at work, the child's at school, it's very hard to make that. Set an alarm. Everybody has cell phones. That's the best thing. If it's a tween who loves to use their phone, make them use it for something useful other than just Facebooking or texting their friends. Use the things you have for their benefit. So how long will you have to take the medication? It depends on the epilepsy type. Some can outgrow the epilepsy. Some will need lifelong. So it's important to work and not stop the medication before just take it in your hand and just stop medication. There are lots of times when parents will just stop medication and not even tell us. And the next thing is they're in the ER because the child had another seizure. Well, what happened? Well, he was doing so well, so I just thought, let's stop the medication. Well, he was doing well because he was on the medication. It wasn't because he's doing well so he can come off the medication. So be sure you communicate. So some of the shifting gears a little bit to common side effects. You can have delayed motor responses. This means you can be a little more clumsier. Low self-esteem, depression, hyperactivity can also happen. Changes in level of consciousness can happen. Memory and attention problems. So while you're trying to treat epilepsy, the medicine is still going into the brain. So the medicines do work on all different kinds of receptors. You cannot separate them out. So you can have cognitive and motor side effects from the same medication that's trying to control one thing. So imbalances can occur. Poor reading skills can happen. Language problems, mood swings, that can all be part of the side effects of medications. What is an EEG? It's the most commonest test that we do as neurologists. And we detect abnormalities in the brain waves that are happening during wakefulness and during sleep. Sometimes I want to really see what is happening during sleep. And if you just get a child and he doesn't fall asleep during the half-an-hour test, I may ask for it to be repeated. That's because the brain, if you know, it looks like a walnut or a pecan. It's got grooves in there. So the EEG can only record the surface. We cannot record from the depths of the grooves. So that's why somebody who has seizures even every day can have a normal EEG as well. So parents may say, you know what, you're saying my child has epilepsy, is on these medications, but his EEG is normal. That's because we have not been able to catch the abnormality on an EEG. If it looks like a seizure, smells like a seizure, it is a seizure. It's a clinical diagnosis. The tests only help us so much. So that's why sometimes we'll order more EEGs. Sometimes it takes about 4 or 5 EEGs to really find an abnormality, because it just depends on what the brain is doing at a particular time when we're doing the test. During the test, we do stimulation. So we flash lights. That's called photic stimulation, because certain epilepsies can be brought about. And people think that, oh, it's like everybody will have seizures if they see flashing lights. No, that's a small proportion. Only 5% of epileptics will have EEG, will have seizures that are provoked by bright lights or flashing lights. And these are not just your lights in the disco. It can also depend on the computer resolution. On your phone screen, everything has a different frequency. And the other test we also do is a hyperventilation, because that changes the acid-base balance in the brain and can bring about seizures or abnormalities on the EEG. This is what a normal EEG looks like. This is when somebody is awake. The blue lines are the left side of the brain, the right side is the red lines, and then these black lines are the middle of the brain. And then we have the heart rate. So this is 10 seconds of a child's, of any person's brain activity when they're awake. This is a normal, good-looking EEG. This is what happens when somebody's asleep. So as you can see, it's higher amplitude, it's a little slower, and this tells me that the child is asleep. Now who thinks it looks normal? Nobody, right? So this is this is a very abnormal EEG. If I turn the page upside down, it would still look as bad. It's not going to change anything. And this is from a particular type of epilepsy that happens in children with infantile spasms. And this is not a good kind of epilepsy to have. Another EEG, this is worse during sleep. The EEG was a little abnormal when the child was awake, but this child was having seizures and was actually having difficulty with speech. So you cannot always have, you don't always have to have seizures, as I'm saying. You can have other abnormalities. So he suddenly dropped from saying 30 words to 2 words, and he was actually squeaking yes or no. So this was his EEG. Another EEG when the child was awake. This child was having visual hallucinations and then a lot of drooling and followed by lethargy, and that was it. And with some eye deviation. And this was only during sleep. So this was when the EEG was awake. I don't have her sleep EEG. So, as I said, it's not uncommon for somebody to have a normal EEG after being diagnosed as an epileptic. And sometimes we like to do long-term monitoring, so we admit the child to the hospital and observe the EEG over 24 hours. This is a CAT scan, example of a CAT scan. So that first one is a normal CAT scan of the brain. This is somebody who's got bleeding in the brain. And this is somebody, so that is from a bleeding from a tumor. And this is bleeding because it had a head injury. So this is, so just giving you a few examples of what a CAT scan looks like. So a CAT scan is quick, cheap, fast, but it gives you a lot of radiation. It doesn't give you more information other than something that's acutely going on. So that's why we don't like to do it unless it's in the emergency room setting. An MRI gives me more information. Why? Because I can look at your head if I slice it like this, or like this, or like this, which we cannot do with a CAT scan. This gives you more detailed information, as you can see. Let me go back and see. So as you can see, we can only look in a brain on a CAT scan horizontally. We cannot look in all these various ways. So we get a lot more information, and it does not have x-rays. So pregnant women can also have this, so it's not a problem. And it can find abnormalities that a CAT scan will never ever show. But it does take time, and sometimes the children have to be sedated. A brain MRI on an average takes about 45 minutes to do. A CAT scan will be done in 5 minutes. Spinal tap. This is another procedure we do because we want to check the fluid around the brain. So the fluid around the brain actually goes all the way into the spinal cord, and a lot of women here who've had children, may have had the epidural. So this is just exactly the procedure for an epidural, except we are not injecting something, a medication to numb them. We're actually removing some fluid to send it off for sophisticated testing to help us figure out what the cause of the seizure might be. So we'd lay the child on their side. We curl them up. If they need sedation, we sedate them. If they need something to relieve their anxiety, we give them a tablet so that they are calm and relaxed. And then we go between a particular spot in between the different spines, between the lumbar spines. We can't just go anywhere along the spinal cord because we'll damage the cord. So we have to go where the spinal cord ends, and then we just, as you can see in the bottom one, the needle is in there, and we're just drawing fluid. Actually, sometimes this is easier to do than a vein because you need to put the tourniquet, try to poke, and you can't find anything, then you go try to find another vein. This is, we know exactly what spot to go. It sounds scary, but it's actually less traumatic than sometimes a blood draw. How to read a medication label. So it's got different parts. Be sure that it's prescribed for your child. Be certain that the brand name or generic name is on the medication and it matches what was prescribed or what was discussed in clinic. Make sure the instructions match what you said. Sometimes with this electronic system, we get messages, oh, refill needed, comes from the pharmacy. It does not match if I've gone up on the child's dose the last time. And sometimes if I'm in a hurry or if I do that and the computer does not allow me to do it, the old prescription can go in. This exactly happened this morning. I'd increased the dose, I looked in the child's note, I sent the prescription. 5 minutes later, I got another email from the pharmacy saying, asking for the old dose. So I called the pharmacist up. I said, what's going on? Oh, we have 2 prescriptions. I said, well, I want the one that's the higher dose because I increased the dose 3 months ago, and that's the prescription I gave at that time. So I'm going to deny this other one. So be careful. Don't take the wrong dose home. So read that label. And as I said before, make sure it's the same manufacturer. If it's a generic, just question the pharmacist. Check the size, shape, everything of the medication. And if it's different, then talk to your pharmacist or call the office. Precautions, know all the medicine and dosages. Take the medicines at the prescribed times. Don't stop without discussing. Dose will change as the child gains weight and grows. We'll only grow horizontally at our ages. The child is growing vertically and horizontally because some side effects include weight gain. So the child's dose has to be caught up each time when I see them. So sometimes, depending on how fast I think this child is growing, I may want to see them every 3 or 4 months because I think this kid is going through a growth spurt and I may need to adjust medication sooner and get a weight rather than see them every 6 months. If it's a teenager who's grown past their peak, I may not want to see them if they're well controlled because I don't want to really change their medication so much. But for younger children, they're growing, their dosages need to be updated with their weight. Don't forget to travel, like in that family I was telling you about, Dr. Gitanis' patient, hypothetical patient. It's very necessary to make sure that the child is sleeping. Even if it's a weekend, it's Thanksgiving, make sure that the child has adequate sleep. There's a reason why nature made sleep. Actually, I have parents actually ask me, what's the point of sleep? And I was like, how do I explain to you how much sleep is important for consolidating memory, for resting, and for all the other God knows things that we still don't know about the brain. Avoid any medicines that you want to take over the counter without discussing. The internet is on your fingertips. You can even do that research. Go online and see if your child is on Keppra. Has there anything been reported by what you're giving? I say it's okay to give your child anything that you think that's going to be fine as long as it's not going to cause side effects. If it makes you feel comfortable going for St. John's wort or something, as long as it's not interfering or causing harm to the child, it's okay. And if it's a child who has seizures with fever, use cold packs, medicines to reduce the fever, and anything else that you think might be causing the seizures. Coming to first aid, stay calm. You cannot help your child if you're not calm. And reassure bystanders because you really don't want to create chaos over there. Track the time. That's going to be the key for you to be able to know when to call 911 or what to do. For my patients who are under the age of 5 or 6 and there are multiple kids in the family, I actually suggest to parents to do CPR training. Just go to your local fire station or Red Cross and you can get CPR training. That gives you something to do and some control by the time you call 911. So track the time. Lay in an open space. Turn the child to one side, because if there's any vomiting or any difficulty swallowing saliva, they won't choke on it. Cushion the head so that if the head is moving repetitively, just placing your hands even under the child's head will be enough. Protect from any hazard. So supposing a child is having a seizure over here, I don't want them to fall down. If they are near the table, I don't want them to hit their leg and injure themselves. So make them come into the middle of the room or somewhere. After the seizure is over, actually during the seizure, calm your child. You've turned them on their side, calm them, because sometimes they can be aware of what's going on. They may not be able to respond, but they can probably hear you. So just comfort your child so that they know that their loved one is nearby, and it's not as terrifying for them as it would be if they're just bystanders, creating chaos around them. And make sure the child's coming back. In the meantime, you're timing the seizure and providing what support needs to be done, and then document the seizure activity as I gave you the first sheet, so that you can communicate what's happening with the seizure during the seizure. And then if you have Diastat or Midazolam, which has been prescribed for seizures lasting more than 5 minutes, then you give. The reason we say 5 minutes is because most seizures do not last more than a minute to minute and a half, at the most 3 minutes. By 3 minutes, I say, get the medicine ready. So if you're not panicking, you're timing the episode, you're saying, Dad, go get, I'm with Johnny, go get the medicine. Somebody can go get the medicine, and by 5 minutes it's not going, then you need to get the medicine. The reason is because if a seizure is lasting 5 minutes or more, then the likelihood for ending up in the ER and requiring other medication to stop the seizure is higher than not doing that. So, just in a pictorial way, what to do. So cushion them. If there are any glasses, remove the glasses. If somebody's wearing something tight, just loosen them. Turn on, then time the seizure. Don't put anything in the mouth. As I said, the tongue is not going to go anywhere. Actually, if you put your finger in the child's mouth and they chomp down, you can't go get help or call anybody. Then you're stuck with the child. And actually, they can damage their teeth if you put something in their mouth. Some parents put towels so that the child won't, clench down. Don't do that, because you're going to suffocate the child. If some children have an ID, if it's school, then the school should know. If they're outside somewhere in a mall, having a bracelet or some identification or a seizure plan with the child always is a good idea. Don't hold the child, do not restrain, and then once it's done, you take care of the child and do what you need to do. If they're tired, if they're sleepy, but they look back to be their baseline, let them go to sleep. Sometimes they may need Tylenol for their headache. Give them the Tylenol, let them go to sleep. For seizures that are not convulsive but are more of the complex partial type, don't try to hold them. Don't try to make fun of them. I'm saying fun of them. This is for you to go and tell anybody else in the family if they're witnessing. If they're if they've gone for a sleepover somewhere, just let the other family know what to expect. If they walk about in a daze, make sure you're following them and make sure they don't end up at the staircase. And again, reassure them that everything will be okay. Again, track the time. Timing is very important. And then when the seizure ends, just see what they would like to do or what they usually do and help them with that. So what I say is let the teachers know, let family know, let parents whose home the child is going to go for sleepovers know. Because I'd rather that somebody is aware and is able to help my child than just hide from them, oh, I don't want them to know that my child has seizures. Who's going to be affected? Your child will be affected. Who's going to be helped? Your child will be helped. So it's better to let people know. And that's one way we will destigmatize epilepsy. Explain to them that it's a medical condition, it's nothing, and it's very well controlled, or whatever the situation is with your child, and let them know that the child goes to school, the child does activities, it's just like any other child in any other way, so that they don't ostracize the child from the other children. And slowly and gradually we'll get people to know what epilepsy is. So these are some statements for some parents. I'll just let you read them regarding their child's epilepsy. Avoid overprotection. That is going to be harmful to a child. Just this morning I was talking to one of my colleagues, and she said, well, they heard that this child was not going to do well before he was born, you know. So the first 10 years of their child, he was kept home. When he was 10, they started letting him out into the world to meet other kids. He just couldn't relate with anybody. Don't be overprotective. As I say, I don't like my patients in a cage. If they want to go, you know, there's one kid of mine who wants to go scuba diving. I don't think that's a great idea. And I said, you can go swimming, you can do other things, but not scuba diving at this time. So within limits, reasonable limits, you should allow your child to have a life, because he may go behind your back. You don't want that to happen. Okay, so encourage all activities in school. Make sure if that's something that the child likes to do, let him enjoy it. If he ends up not enjoying it, and it's harmful for him, good, at least he's tried it. Supervise a child who is swimming in a gym on high bars, doing gymnastics, or anything that you think is dangerous. The teacher should know about it and should supervise. And then epilepsy does have an effect on the family unit. I've had parents who've divorced. I've had siblings who've grown up resentful because mom and dad took the time for the other child and did not pay more attention to us. And then the siblings also report that, you know, people make fun of us because our brother or sister has epilepsy. That's where we need to destigmatize it. The siblings feel left out because of these reasons, and then they themselves start distancing themselves from their sibling. So how can somebody live successfully with epilepsy? Be positive, be supportive, and make sure you have a team approach. Make sure that you let your child grow up without insecurity and fear, because what the child senses from you is what he's going to grow up to be. Praise them for their accomplishments and emphasize their potential abilities. So with a little preparation before your next visit, you will have some idea of what to do, what not to do. And as I'm sure, this is not the first visit for you all, but you may have learned something that might help you with the next visit or so.